Hello, everyone, and welcome to Backchat. Welcome to Move with Scoliosis, your channel for everything to do with movement and scoliosis. And welcome, of course, if you are watching this on the replay. Now, we are at the moment live on YouTube here. So if you are joining us live, then feel free to use the chat if you have any questions. Or if there is anything, you want to ask or contribute, then we are always excited about communicating with you guys, obviously, as well. So I can see quite a few of you joining right now. Today I've got a guest again. I'm really excited to talk to him here today. He was a guest on the podcast 4 years ago. We just talked about this, and I couldn't quite remember how long ago it was. So it was quite a while ago. So definitely time to get an update from him. So I'm going to bring him on right now. So we've got Dr. Tony Nalder here from the Scoliosis Reduction Center, and he's an expert in all things conservative treatments for scoliosis. So welcome.
Yeah, I'm glad to be here again. I mean, I definitely enjoyed our conversation last time. So excited to be here and excited to share, some of the new stuff that's come out over the last 4 years.
Yeah, absolutely. And I do remember as well, I really enjoyed talking to you last time, and it was relatively, well, it was just in the pandemic, I think, or just afterwards, something like that. And there was not so much communication going on yet, I feel, between kind of different modalities and different treatments, even though obviously in your clinic you've always had lots of different people working together on this topic, which I think is really exciting and really beneficial for people.
Yeah, for sure. The good news is that the conservative movement for the treatment of scoliosis is only growing by leaps and bounds. And what we're learning over this last 4 years is that this seems to be pointing in the right direction. Really treating scoliosis conservatively, especially in the adult patient, to be really the preferred method, because if that's something that we can, avoid, like, invasive spinal surgery and keep people functional and working well, that tends to be the goals community-wide, which is very, very, very interesting. And it's across the world now. We're seeing, clinics in China and Taiwan and Europe and making some really strong strides on how we can manage patients with scoliosis.
Yes, absolutely. So we've got so many things. Well, I've got so many questions for you, obviously, today. What do we have to know as adults with scoliosis? How is this different from maybe, because there's a lot of kind of information out there about teenagers with scoliosis and what to do. What is kind of the difference? What do we need to know as adults?
Yeah, so adult scoliosis progresses because of different reasons, and so there's two misconceptions that are still permeating in doctors' communications to patients. Number one is that once you're an adult with scoliosis, you don't have to worry about it. Like, it's not going to worsen, right? That's misconception number one. We know curves progress, but they progress very, very slow. They progress very slow, but they accelerate with time. So, meaning as a patient ages and the curve gets slowly bigger, it starts getting bigger faster. And this acceleration can be, unfortunately, relatively rapid again in later stage life. But by then, normally the curve has gained so much speed and size, it's very difficult to manage, right? So the concept of doing nothing about your scoliosis until it becomes problematic is normally not good advice, but it's still recommended, right? And then two is that scoliosis in the adult form, no matter how little or slow it may progress, it's more likely to cause pain. It's not relative to your total size. It's relative to how much you worsen in the adult form. So what I'm trying to say is that somebody could only progress from like 20 to 25 degrees in the adult form, and that 5 degrees could initiate pain. where somebody could have a 60-degree curve as an adolescent and have no pain and hold it at 60 degrees their whole life and maybe develop no problems or pain. So the progression in the adult form is a different animal because it's compressive over time. And this compression is what leads to problems and symptoms and things that patients tend to feel. And then lastly is the prognosis for spinal surgery is very poor in the adult person. So therefore, they're normally not apt to do it. So waiting till your curve becomes severe enough to start considering surgery normally is not a good way to go throughout managing your scoliosis, because at the time you would maybe consider scoliosis surgery, the prognosis of you recovering well is also very poor. So therefore, when you look at all these combinations of factors, like, you want to always manage it. Like, I mean, you want to be like, your life doesn't have to be consumed by it, but you want to be keeping an eye on it and trying to do what you can to mitigate the progression and the problems that it may lead to in later stage life, because that's when things start to turn and it can be very difficult to manage.
Yeah, absolutely. And we did have a few weeks ago, we had Dr. David Hanscom here on the podcast. He was a spinal surgeon for a long time, and he actually quit his job because he basically saw that it's not doing any good. So
yeah, especially in adults.
Especially in adults, yes, and absolutely. And he was, his whole thing was it's not going to solve your problem of pain. If that's why you want to get the surgery, that's probably not going to be the solution. So for anyone who's kind of considering it, you might want to listen to that previous episode as well. It's really, really good. So I always find that there is a bit of a difference between, so you kind of, with adults, you've got kind of two categories, isn't it? You've got kind of the people who, like myself, were diagnosed as a child, and the word scoliosis is very familiar to us. We've kind of been hearing it all our lives. And then there are these people who maybe kind of in their 50s, 60s, all of a sudden get told, oh, yeah, no wonder you've got pain because you've got scoliosis. And they are like, what? I didn't even know this.
Yeah. And and so there is two true different types. And we call this adult onset scoliosis and then adolescent scoliosis in the adult form. Now, the problem is that we don't catch every adolescent case. We only believe we catch about 30 to 40% of cases in adolescent form because they don't progress enough to become visually noticeable. And the only symptom in the adolescent stage is vision, is what you see, postural. So many cases go undiagnosed. Maybe they have a 15-degree curve, 20-degree curve, and they don't know. And then the curve progresses in the adult form, and somewhere around 40 to 45, 50, they start feeling pain. They get an x-ray, they now you have scoliosis, and they may have actually had it in the adolescent form. And the other type is truly adult onset. And adult onset is normally, one of two main categories, either traumatically induced from some kind of trauma or injury that happens significantly to cause a scoliosis immediately, or some small trauma that happened years and years and years ago that causes a small shift and causes that area to degenerate, and that leads to degenerative scoliosis in the adult form. And those are sometimes they're easy to identify. Oh, this is definitely an adult onset case. But sometimes when you're looking at, a 55 or a 60-year-old patient that has a scoliosis, sometimes it's hard to know. Is this an adolescent case that was undiagnosed and now dealing with an adult form, or is it truly an adult onset? Sometimes it's very clear, but sometimes it's not so clear. But understand the vast majority of patients we consider to be adolescent cases in the adult form. We believe 70+% of those adult cases, that's what they have, unless there's some clear indication to tell us something different.
And would that make a difference from your point of view, like in terms of the exercise you might recommend or the treatments you might recommend?
Yeah, so the adolescent and the adult form tends to respond better, meaning they tend to have, because they've been developing and growing with this curve for years and decades. So they grew and they adapted to it, where the true adult onset scoliosis tends to be more painful, cause more pain. There tends to be a lot more degeneration and damage in the spine. There tends to be more stiffness and rigidity in the curvature. These are much more difficult cases to handle. The problem is that these adolescent cases become degenerative because they transform into that. So we can see degenerative findings in an adolescent case that's progressing in the adult, and that's why it's hard to differentiate. But overall, that's I think that category, what I'm telling you is correct. That adolescent cases in the adult form tend to respond easier and better, where the ones that truly are adult onset because of degeneration or trauma are definitely a little bit harder to correct, and they're having more pain at a smaller curve.
Yeah. Yes, that's what I find as well, that sometimes it's not necessarily the bigger curves that have more pain, as you kind of mentioned before. Sometimes and very often it's the people who have just been diagnosed and who might have a smaller curvature that actually have the most.
Yeah, there's no relationship to size of curve and pain in the adult, unfortunately. Otherwise, it would be easy. But what we do know is if it is a patient that, like you, that had adolescent scoliosis and it progressed in the adult form, and we know where their pain initiated. So let's say somewhere around 30 or 40 years old, their pain started, and they knew a curve number, let's say 40 degrees. And before 40, they didn't have pain. If we can get them below those numbers, normally their pain resolves a lot, because that's like their zero. Like whatever you stopped growing with is kind of like your neutral or your normal, or what we consider your zero. And it's when you add to that number in the adult form is when it becomes compressive, because while you grew with scoliosis, you adapted very well.
Yeah.
That's why you can, the biggest curve I've seen in an adolescent case, 150 degrees. And that child walked in, functioned like most other kids, and literally had 150 degree scoliosis, which is crazy. Like you could think that you can have that size curve and have no pain because they're growing and adapting around it. In the adult form, when the curve worsens, you can't adapt as well. You compress and your body gives to the curve, and that causes discomfort and pain.
Yeah, absolutely. So before we talk about kind of exercise and movement, I wanted to talk about bracing a little bit, because this is a topic I always get asked about this, and this is not my my area of expertise, obviously. So what's your take on adult bracing?
Yeah, so there's a wide range, and that's actually good. There's a whole wide range of how we can use braces in adult form. So let me try to kind of make all those options kind of easy to understand. So I would say the number one reason why I see patients in the adult form is because they have pain, right? They're normally seeking treatment because of pain. Now, I do patients seek treatment because they're managing the curve and they're worried about progression and they're worried about it getting worse. But normally what initiates it is pain. So if we're looking for pain relief, bracing can be effective for reduction of pain, because a corrective style brace, now this is important to understand, corrective style brace, not one that's immobilizing the spine, or one that's elongating the spine and trying to reduce the structure or improve the structure. Corrective style bracing can be effective for pain relief because of that exact reason. It decompresses the spine while you have the brace on. And normally pain relief bracing is considered very short-term bracing. Typically, 4-8 hours of bracing a day. So it's not a lot of high dose. And the goal is to try to decompress the spine as using the brace. And patients will use it like instead of if they have pain in the middle of the day, they'll put the brace on for an hour. It decompresses them. They feel better. They take the brace off, and they use it like that 4 to 8 hour range, and they sleep with it for a little bit. It's not, the goal isn't really a strong reduction of the curve. It's more like just managing their symptoms.
Managing.
More like managing. And it works very well with things that you do, because the more flexible their body becomes, the more they move their spine, and normally the more effective the brace can be. So the two things work really, really well together. And that tends to be a very common goal. However, when we evaluate patients, if we believe that there's the ability to reduce the curve effectively, meaning take 5 or 10 degrees off the curve, then we normally want to shoot for a slightly higher dose. And for most adults that we're looking for just curve reduction, we're trying to reduce the curve some and also manage their pain, I say, okay, go for 12 hours of bracing. So we increase the dose more, and normally the most common dose will be 8 o'clock at night to 8 o'clock in the morning, like a 12-hour continuous wear. And so therefore it's not too obtrusive in their life. They can function, they can do whatever they want. They can go to work, they can exercise, they can take it off and do whatever they choose to do. And we choose this 12-hour range. And it's very effective. I would say that's the vast majority of my adult patients. However, I do have some adult patients that their spine is very flexible. And we think that we can get a significant reduction. What do I mean by significant? 30%, right? And they have, and they want cosmetic improvement. They want to see the shape of their torso change. And I believe it's possible. Well, for these patients, we shoot up to 18 hours of bracing. And
wow.
we go, yeah, almost like adolescent, because they can respond well. And I've seen amazing thing happens in patients that I wouldn't believe possible. I mean, you're looking at 60-year-old patients, 55-year-old, 50-year-old patients, that their body shape actually changed. But they have to be the right person. They have to qualify for this. Okay.
Oh, sorry. Yeah.
Yeah. And I would say it's normally this dose of bracing is not long term. We normally sit there for like 6 to 9 months, and then we wean them down to 12, and then we wean them down to 4 to 8, and then we see what we need. So it's a little different than an adolescent, because an adolescent, we're worried about growth and progression. We're worried about how fast it's. So since we don't have that component anymore, we can do it in a shorter term, right? And those are the 3 options, like this corrective style, 18 hours, 12 hours, kind of like in the middle, and then 4 to 8 for like pain relief.
So is the idea that basically this corrective brace kind of brings you into a better position, and that the muscles then start to adapt to this corrected position, and you go about your daily activities? Is that the idea?
Exactly right. So the brace has two effects. First effect is that it's elongating. It tractions the patient up and elongates patients, and that's a decompressive nature. 2 is because the dose, you can have it on for a period of time, it creates a deformity in a positive way. It helps stretch and elongate tissues in a sustained hold, right? So it has this plasticity effect that can help change the shape of the muscles. And then lastly is because you can be active in the brace, you're performing activities of daily life in a corrected position, which is amazing, right? Because that's the strongest exercise you can ever perform, is brushing your teeth in a corrected position, cooking, eating, walking, and you don't have to think about it. The brace is putting you in this corrected position to help the muscles retrain themselves in a way.
So I had a question before already. So this was from Laura. And she is saying, I would like to ask Dr. Nardo, what does he think about going for a walk with a soft brace? And she's saying elastic girdle. So I'm assuming this is not something, I don't even know what exactly it is. But I'm guessing, you probably.
It sounds like a waist trainer. Yeah. Got it. So those things, I'm not necessarily against them, but they're more supportive for like muscles, not necessarily structural. The thing with every scoliosis is that it's structural in nature, meaning that in order to actually reduce the curve, you really have to push on it. You can't squeeze it. And that's the difference between a support and a corrective brace, right? Now, I'm not necessarily against support, because if somebody has pain, sometimes a little bit of support can help them relieve their pain, but it's not going to have the effect that I mentioned in the 3 options that I talked about.
So we have another comment here. Hello, I'm 58 and mine is due to a hemivertebrae congenital, was not fixed, now also degenerative. So there's probably quite a few things going on here.
Yeah. So so when we know there's different kinds of scoliosis, right? We know there's idiopathic, which is by far the largest group. But however, there's 5 to 7% of cases that are congenital. They have a hemivertebra. They have a bone that's actually that in utero never fully developed into a full vertebra, and the shape is wrong. And so there could be more limitations in the congenital case than there could be in a non-congenital case. And then, of course, we know we have neuromuscular cases. They have many other complicating factors with scoliosis, and we have to deal with all those factors. So there's no one-size-fits-all treatment for any scoliosis patient. Saying somebody has scoliosis is saying like you're having a sandwich. Like, well, what kind of standards and how many?
I love that.
Like, yeah. There's so many
I'm
different
going to use this. This is good.
But generally, when we talk about scoliosis, and what I'm talking about is the most common type is which we call idiopathic scoliosis, and we can't tell you the reason why somebody has it. And that's the when I talk, that's what I'm addressing. But understand there's many variations and many variables.
Yeah. So with this, so just one more thing about these braces. So I'm very aware of the braces for the kids. I've seen loads of them. They're quite kind of hard shell plastic braces. Are they the same for adults or the ones that you're kind of?
Great question. So with corrective style bracing, the idea is to optimize the improvement we're trying to achieve with that particular patient. So some patients may receive a very similar brace to an adolescent because we're shooting for those 18-hour range. Other patients may not have such an aggressive brace because we're more in that 4 to 8 hour range. So it's customized for that person. But the key to bracing is the person who designs it and fits it. Mm-hmm. There is no name on a brace that's going to guarantee effectiveness. So, and that's one of the most frustrating things because it is an art, even though there's a lot of computer programs helping us now and we use CAD/CAM design, but ultimately the design and then the fitting to produce the effect that we want is by far the most important thing. But in our model, we're almost always using a hard style brace, especially in older patients because they're so rigid. Their spines have become so stiff and rigid, and they become so compressed, and soft bracing would not affect the size. It could help them with pain, not disagreeing. It may help them with some pain and discomfort, but if we're trying to affect size and decompress, we need something a little harder, something that's going to have a greater force or impact on the spine.
Yeah. So what about, so you mentioned, I think you said some people would sleep in those braces as well. Is this something kind of you would be worried about if we kind of sleep in the wrong position with scoliosis, that our curve would secretly progress at night?
Great question. So I get asked that a lot. Like, hey doc, what's the best way to sleep? I have a right thoracic curve, and my answer is the most comfortable way you can find sleeping, because sleep itself is by far the most important factor. You have
that's usually what I say as
well. Yeah. So you and I agree. However, a brace can passively provide forces to the spine, so your sleep can have some corrective forces. I don't think there's any position somebody can get into that's going to help their curve. Now, interesting, there was a study a long time ago that this doctor put together, and it's actually one of the causation factors that people can, while developing and growing, you can be in what they term it's called a prerogative sleep position that potentially could affect or develop the scoliosis. And they draw this position that when you're rolled halfway on your stomach with your hips kind of rotated the other way, and your leg kind of out this way, and your arm kind of out this way. And they say if you're in this position, you're promoting a scoliosis development. It's a theory, right? We have no evidence other than theory, but it's an interesting paper, and this was done some time ago. And so do I think you can position yourself so complicated in a way that you're going to undo all the scoliosis and be able to sleep? I don't think that's possible in my opinion, but I do like people sleeping in a brace because it is providing a passive correction.
Yeah. So we've got a few comments here coming in. So Leila is saying, thanks for this conversation. I'm listening from Vancouver, Canada. Diagnosed at 69 with an X-ray, started with lower back pain, and now the pain moved to my hip and leg. All my left side is weak. And I think this is a great transition into what we started kind of discussing before we went live. And you were talking a little bit about kind of the latest things that were coming out at the latest SoSort conference. Do you want to talk a little bit about this, the kind of
Yeah,
Which
yeah,
one is the weak side and which one is the strong side? Because there's always questions about this.
yeah. So Layla, I mean that was her, that lady that's watching. I said right, Layla. So unfortunately, Layla, you're presenting yourself with the most common symptoms that we see in scoliosis. Is it's going to be low back pain on the left side, going down the left leg, affecting the left side of the body. It's by far the most common symptom that we see with patients with scoliosis, because the most common lumbar curve is a left curve, right? So that's what we always see, unfortunately. So the debate here is what's happening. So let's kind of look at the big picture. What happens when you have scoliosis for a long period of time is that your body's reacting to the curve. And what ends up happening is that your body center starts to switch, and your brain in time and space, as you're living, is contracting muscles to support an asymmetrical spine. And this contraction is autonomic, meaning it's happening without you thinking about it. Unlike your car, like a car, if a car shifts and becomes out of alignment, the shocks can't change; they're fixed. So this will cause asymmetrical wear and degeneration in this, and with no reaction from the car. Your body is different; it shifts, and now the brain goes, "Whoa, there's more weight over here versus over here," and it starts contracting asymmetrically in order to hold you upright. Because if it didn't do that, you would just continue to fall over. Mm-hmm. So this reaction is something that's built into our treatment model, and it's been since we've been taking care of scoliosis patients for 28 years. However, therefore we look at causation. So what comes out is when we look at a curve, that it's very easy to think that the muscles inside the curve are pulling the spine down, and that is why scoliosis is developing. So these muscles would be too strong, and it's easy to think that the muscles on the outside of this curvature are too weak and being elongated, and that's why this whole asymmetrical muscle development is the reason why patients develop scoliosis. And that theory still exists. Like people still say. However, there's some interesting data coming out, because in with what we treat is that we think of more of the reactive idea, that your scoliosis is developing and the body's reacting and contracting muscles in time, in space, and in time and in need. And we always thought that the muscles are weaker inside the curvature clinically and stronger on the outside. Exact opposite of what you'd think if the muscles were causing the curve. Well, there was some data that was put out this last SOSORT, which is the largest non-operative rehabilitative treatment organization in the world regarding scoliosis. And these researchers in Australia did some testing of muscles using MRIs to look at two things: volume of the muscle. Theoretically, the more volume a muscle has, the stronger it is and the more it can contract. And then secondarily, fatty composition. The more fatty composition within the muscle, the weaker the muscle would be and the less it can contract. And what they found out was, when they looked at muscles within patients, that in the concavity, where we think the muscle would be stronger, it had a much higher fatty composition compared to the muscle on the outside of the curvature. So the exact opposite. But what they did find was the volume was bigger in here. And that's because as you make the curve, the muscle gets shorter and it increases its volume. So they found the exact opposite that we would think that if the muscle were actually causing. So volume bigger in the concavity, but more fatty infiltration in the concavity, and the exact opposite in the convexity. So it almost goes to show that we don't really understand why the scoliosis is actually happening. And the truth is, you have to look at every patient individually and define a program for them, right? Mm-hmm. So that left side becoming weak for Layla could be happening because she's shifting over to that left side, and it's the body's overworking and it's just fatiguing faster. Yeah. And before that happened, and maybe it was stronger initially because it was holding up more weight for a while, and it got stronger, but then it starts to chronically fatigue in time, and it gets weak and collapses quicker. So what we notice with scoliosis patients is they have a lack of endurance. That the longer they hold the curve and the longer they go without treating it, their endurance starts to decline quickly. And patients describe that as weak. Is it weak, or is it just doesn't have the ability to sustain a contraction for as long as it did before because it's fatiguing quickly?
Yeah, and I always, we always talk about this in my membership as well, that, people are saying, oh, I've been for a really long hike, and now my back is hurting. And it's like I always say, it's like your muscles are basically have to work overtime, right, to keep you in this upright position. So there is no surprise really that we might get a little bit we get fatigued more quickly, probably.
Yeah.
So here we've got a couple of more comments here. My daughter has idiopathic scoliosis S-shape with 50-degree each curve. She is 14 years old, wrist at 2, no pain. She uses a Chanel brace.
Yeah. Chanel brace.
Yeah. Can the brace help? I guess is her question, because she's already got the brace, so hopefully.
So let me explain why she's asking this question. So typically, and I can speak for what we know happens in the States. However, this tends to be globally, is that when curves get into the severe range, typically greater than 40 to 45, most doctors consider bracing to become ineffective at this point, because the goal of a majority of bracing in the world is to slow down progression during growth. So when somebody is still RISR 2, means they're still growing. RISR 5 means they're fully done growing. RISR 0 means they haven't started their RISR cycle yet. Right. So she's RISR 2, so she's a little under halfway. So the goal when they give this brace, they're just hoping it can hold it the same, right? So that's why she's at, can the brace help? Well, hopefully that brace that she has will at least hold it. But our approach to bracing is very different. Our approach to bracing is like braces on your teeth. We're not just trying to slow down the progression. We're actively trying to reduce the curve, because we know the smaller we can make the curve in the adolescent form, the less likely it is to worsen and the easier it is to manage in the adult form. So we're always trying to reduce it. So our goals for bracing isn't slow down worsening, but to physically reduce the scoliosis. So can a brace be effective for her? Yes. Just because it says Chanel brace, I have no idea what kind of brace it is, because I don't know how the person designed it and how he fit it. So I've seen Chanel braces that are really good, and I've seen Chanel braces that are not so great. So unfortunately, the answer is very vague for her. But yes, if she had a good brace with good therapy, good home care, good office therapy, good exercise program, could she help, meaning reduce the curve during growth and end her adolescent with a smaller curve? I think it's possible. Definitely.
And then we've got Diane saying, I've heard braces can weaken muscles because you're not using them. What's your opinion?
Yeah. And I'm glad that question came up, because I was anti-bracing for maybe about 15 years of my scoliosis treatment program. And the reason why, because the only brace I could get patients in was something called the Boston brace. And Boston braces are squeezing style braces that just squeeze the body to try to hold it where it was. Okay. And the squeezing effect does weaken muscles. And that was my whole approach. However, I started getting some data out of Europe that bracing was being effective at reducing severe curves, meaning surgical level curves. And I was like, okay, well, wait a second. I didn't get this experience, so I stopped using braces. So I took 25 of my patients this exact year, and I sent them to a local surgeon here in Florida, and I put them all in Boston braces, all 25. All 25 of those cases in a direct row, all worsened, every single one. I had better results with no brace. So I proved to myself again, bracing doesn't work, right? It doesn't work. But then I got introduced to this concept of corrective bracing. And I had one of the manufacturers come to my clinic and sit down with me and show me a corrective brace. And I go, okay, let me try some. And the minute I stuck them in a corrective brace, I was like, oh, wow, I can see the difference. I can see the difference. And now bracing is integral in my care, because I was so anti-bracing before, because if you squeeze, it doesn't work. A corrective brace doesn't squeeze, it pushes. It uses biomechanical principles to push the spine into a straighter position. It doesn't allow movement that worsens the scoliosis, but allows movement to improve the scoliosis. So what we find is the exact opposite. We find people become stronger because they're exercising the right muscles that we want to make them stronger. In our clinic, I was so adamant that bracing weakens muscles that I tested my first 25 patients that I put in corrective bracing, and I did a V sit-up test. I just had patients hold a V sit-up, and I checked them 3 months later, and 6 months later, and 9 months later, and every 3 months, their time or their ability to hold a V sit-up increased. It did not go down. And then I also have something called dynamic motion strength. It's like an EMG for muscle strength, and we can test their muscle activity. And in the brace, the muscle activity goes up.
Oh, wow.
Yeah, it doesn't go down because they're being squeezed in the body, and not squeezed, they're being corrected, and the body's reacting and using muscles. So we saw muscle activity increase in bracing, not go down. So the whole concept of bracing weakens muscles only exists if you have the wrong brace.
Right. So if it's a brace that kind of just holds you in the position that you're in already, you just kind of rely on it.
Yeah.
It's like leaning against the tree, I guess.
Yeah. Boston bracing was born from casting, from using casts. And that's the reason why it acts the way it acts. And so the reason why they stopped doing plaster cast because it takes too long for the surgeon. So they said, okay, let's just come up with this bracing model, which is a Boston brace, and it's a prefabricated brace that people can stick on. And that's where it stemmed from. And the same design in Boston braces that existed 20-something years ago exists today. They make them better because they use measurements and scanning technology, but the design is almost the same. I have patients that come in with Boston braces. They can have one can have a lumbar curve, one can have a thoracic curve, one can have an S curve. They can all share their braces because they look almost the same, right? And when you look at it, because they're not trying to correct, they're just trying to squeeze and hold, right?
So would you say this is kind of I'm hearing a little bit of a kind of a common thread probably to what we could maybe say about movement practice as well. That we're trying to correct as much as we can before we start to kind of strengthen and
so
do our movement.
The cycle of improvement is normally to improve flexibility of the curve, reduce the structure, the flexibility, reduce the shape of the spine, then to stabilize that new improvement with bracing and exercise. That's typically the way it works, okay? But the number one reason why patients experience symptoms in the adult form is because their spine is stiffening and they're not moving enough. So with what you do, you can help people tremendously with pain and discomfort because you're trying to induce motion into a stiff area. So I'm definitely a proponent of that type, okay? Because the more movement somebody has in their spine, first of all, the better chance they have at reducing it and managing it in the future. But two, the less likely they are to develop pain. Okay? Now, what the argument that the surgeons will have, and this is something that we is the more you mobilize a scoliosis, the more you open it up, the window for it to worsen. Right? Right. And that is somewhat theoretically could be true, even though we don't know because nobody's ever really studied it. Right? It's theory. So we make sure that when we mobilize something, we have to stabilize it. Right. So we just make sure we stabilize it. And what's the great thing about bracing is that it's a very strong stabilizing factor. So if we can mobilize and stabilize and strengthen, then we have really the best of all the worlds combined into one.
Yes, absolutely. I agree. So a couple of years ago, I decided to train as a Pilates teacher on top of the yoga because I thought the yoga is great, obviously, especially, we've got all the relaxation part of it, which is really, really important for those with scoliosis. And we've got our mobility and, we're increasing flexibility. What I was missing a little bit was that kind of the targeted strengthening and creating stability. So it works really, really well together. And as you say, we need both, right? So Rosalinda is asking, can you fix an S-shaped scoliosis?
Yeah, I love the word fix because fix sounds like, can we cure it, right? Right. There's no curing or fixing scoliosis, unfortunately. I would love to say I can, but what we know what we can do for sure is manage, and in the majority of cases, reduce it a percentage. And that's really what we're looking for. Even surgery doesn't fix it. We're always reducing and managing. However, the good news is that with what's coming out now these days is that the reductions are becoming better and stronger. The improvements are becoming more long lasting. And in addition, that we're also learning more how to manage and stabilize curves more than we've ever have. So that's the good news, is that the treatments are becoming better in the conservative model, but unfortunately there's no fix. I would love to say that's true, but if I ever find a time that we can actually fix it, and even if I got a curve to 0, so let's say I had a small curve that was 15 degrees and we reduced it to 0, that's considered like no scoliosis, or I still won't consider it fixed, because I think the person, if they stopped everything, it will slowly start to regress back, because we're not curing what caused it, because we don't know.
We don't know what caused it. So if it was just the muscles that were pulling the spine into a scoliosis, then yes, then you could probably fix it, right?
Yeah, but it's more than that. So when surgeons, so what really blew me away was when I became friends with the local surgeon here, and I went in and watched the surgery. And when they do surgery, so understand this is what they do. They open up the back, they cut all the muscles off the spine, they remove all the discs, right? And even then, they got to use straps to pull the spine into a straighter position and then screw it together. So if the muscles were causing the curve, they would cut the muscles and boom, it would become completely straight.
Yeah.
And it doesn't. So it shows you that there's more going on, right? This is truly a systemic, entire body reaction. It's not just one thing causing it. It is multifactorial, 100%.
Yeah. And I've heard Schroth therapists talk about there is kind of a cycle, there is a vicious cycle. So the spine is doing this, and then the muscles adapt, and then the muscles also start to.
Yeah. Each one feeds each other, and that's becomes, you have to break the cycle somewhere, right? And the idea with our treatment is you try to break the cycle in every facet. We're using therapy, using exercise, using bracing. We're using try to break all the components of the cycle of progression to try to unwind it some. Okay. But again, it's unwinding some. It's not curing or fixing.
Yeah. So what would be your kind of advice to maybe someone who's kind of just been diagnosed? Let's say that we had someone here who had just been diagnosed, I think, with kind of a significant curvature as an adult.
Yeah.
What is your advice? And probably most likely that's what happens here in the UK. They would have gone to their GP, and he would have said, well, you've got scoliosis. Maybe you need surgery one day, but at the moment we can't do anything for you.
Yeah, and that's the most common thing that's told. Like, an adult gets diagnosed and they're told, "Oh, don't worry about it until it becomes bad enough, and then we'll figure it out."
Yeah,
that would be the last thing I would recommend that you do. I would recommend that you actively do something. I mean, something, as much as you can do. I always recommend that you try to reduce the curve as soon as you can, because if you treat a curve when it's smaller, to make it smaller, you're less likely to have a bigger curve, because the number one factor in curve progression in any age is the size of curve. So as curves get bigger, they want to get bigger faster.
Right.
So if you intervene and treat the curve and reduce it, even maybe not be so symptomatic at this point, maybe you have no symptoms, you just know you have scoliosis, I would still recommend you try to reduce it. Because if you can reduce the scoliosis when you're doing better, it's easier to manage. And then maintain it and monitor it your entire life. Like, that's what I would definitely recommend. I don't like the watch and wait model in any scenario, because all you're going to watch the majority of the time is your curve worsen and have more problems. And then you're going to wish you did something sooner. And that's what tends to be the underlining theme of the majority of patients I treat. And I only normally treat two groups. I treat kids that are rapidly progressing, and I treat adults that are normally dealing with pain and discomfort that wish they did something earlier. So I very rarely see the middle group, between 20 and 40, even though that group has the most potential to prevent problems later on. But they normally not motivated because they're not feeling the effects of it yet, right?
No. Yeah, absolutely. Same here. It's the group that is missing, really. So Sarada is saying, I'm getting cramps on the compressed side of my C curve. What exercises will relieve it? So from what we kind of heard now, so we now know that possibly the concave side is the weaker one.
Yeah. So there's
Would we
your
want to
question,
correct
right?
it?
Right. So here's the answer, and I hate to say it, but this is the truth. We don't know based upon just your curve
Yeah.
shape and size. You have to be evaluated, and you need to be given a custom program
Mhm.
because obviously there's a lot of debate. Which one's stronger? Which one's weaker? Which one needs more? It depends on you. And this is why I really encourage people to get a customized program for you with somebody who understands scoliosis and what you're dealing with.
Mhm.
So what are the best exercises for you? Somebody needs to determine it for you. That's really the best way. Just guessing on curve shape or even guessing on an x-ray isn't really the right way. I guess the most common thing I get it. Somebody sends me an x-ray, says, what can I do to get better?
What should I do?
Yeah, I go, honestly, I don't know. I have to see you. I got to see how you move. I got to see how flexible you are. I got to see where you're strong, where you're weak, what you need in order to get the best improvement. Because just because you have this shape, somebody else could have the exact same shape and they need different exercises and a different program than you do. So it's more complicated than just, I have a thoracic curve or a lumbar curve or a thoracolumbar curve. What do I do?
Absolutely. And you could be someone, right, who's got a terrible curve, high degree in curvature, but you've been doing exercise all your life and you're super fit and healthy. The advice will be very, very different.
Correct.
To someone who's not used to any movement and he's not doing anything.
Yeah, 100%. I agree with you 100%. So that's why I encourage programs like yours, because you take on the person individually, and that's what really matters.
Thank you so much. This was amazing, as always. And I always really enjoyed talking to you. And I think there's some really good golden nuggets here for us to take away. I'm hoping that that everybody's happy with the answers about bracing. I definitely learned a lot more. So I've also been more of the one to say, well, if you're wearing a brace, you're just relying on the brace and you're not doing anything actively. But definitely, it absolutely makes sense what you're saying. Last thing before you go, is there any point in kind of for anyone going on Amazon and buying a back brace, the lumbar support or anything like that?
Yeah, good question. So I like, if you're going to use those supports, you want to use them in times that you think your spine is prone to some kind of injury. So you're lifting, you're cooking, you're doing something that you may injure yourself. I'm into support. Okay, got it. I would rather you support it than injure yourself. Okay. But something for long-term daily use that you want to wear because it's just squeezing you. It's not providing any corrective nature. And we don't know if it's right for you. We don't even know if it's in the right spot. Right. So, but if you believe like you're going to be moving, you're going to be carrying boxes in and out of the house to your car, by all means, wear support, because you don't want to injure your back while you're doing those types of activities. But it's not something you want to use just for daily wear randomly for for health.
Yeah. Right. Yeah. So somebody's asking, what about driving in a car, for example, or if you go on your long hike?
Yeah.
If it's once in a while, I guess.
Yeah, something like that. If you put it on to drive your car because it provides you support and the balancing of the car, you're less likely to hurt yourself. 100%. I'm not against any of that.
Great. So for anyone who might want to kind of learn a little bit more about what you guys do and the type of braces that you're prescribing as well, where can people find you?
Yeah, so my website is Scoliosis Reduction Center. Of course, I have a YouTube channel called Scoliosis Reduction Center. I have a book called Scoliosis Hope. And of course, I have one for adults as well. We see patients worldwide. In fact, I have a lot of patients from UK. And the idea is to get people better, right? To really provide relief and improvement for patients with scoliosis. So I encourage you to go to my website. You can submit inquiries if you choose. And of course, we love co-managing patients, taking care of patients with other providers that are like-minded and trying to provide a structural and functional improvement for patients with scoliosis.
Great. And your clinic is in Florida, I believe?
Good question. Yeah, I'm in Florida, in Orlando, Florida, right next to Disney World here in Florida. So
you can combine the trip.
Yeah, it happens a lot, believe it or not, right? You got the beach one way, and then everything. Yeah, so it does happen a lot.
Okay, brilliant. Thank you so much for your time today.
You are welcome. And again, it was a pleasure being on, and thank you for what you do, because there's a huge need for what you do, and definitely in the adult community. And I use you as a resource all the time. So, thank you again.
Oh, thank you so much.
Mm-hmm.